When he says start rolling, I don't know how to take that given my name, but we'll let that roll. Ta-dum-tsh.
Rolling or rolling?
Roll. There is a D, but no one pronounces it. Strange,
Is it
right?
is it Peyton or Peyton?
Exactly. Who's on first? How you doing, my friend? It's been a
I'm
while.
doing
Well,
good.
we've chatted. I have not seen you in a while, so it's good to see you again.
Yes, very good to see you. We just chatted the other day, but it's good to see you and see you in person. You look about the same as the last time we chatted, which is good.
This is good. It means I'm still me.
Still you. You didn't change. No cardboard cutout.
No, not yet. Not yet. Aging is a wonderful thing, though, so who knows in the future. But yeah,
So
before you
it's
jumped on, I said to Jeff that technically this makes you the master of master classes because you're our first repeat guest. So don't let that go to your head.
don't worry. I will not. No worries.
Fair enough. So last time we had you on here, we talked all things cell danger response. To give everyone a brief recap, right? We talked about the concept of the cell danger response, meaning the body's choice to conduct its biochemical activities in an appropriate manner given some sort of external and internal stress, infection, toxic load. We talked about the concept of homeostasis and allostasis, and we got into a little bit of, I guess, insights and pearls when it came to running labs.
Hmm.
So since then, I have had a lot of thoughts about things I wanted to ask you because, you've released a book with Dr. Kelly Halderman. You
Hmm.
have probably grown as a professional since then. And since I have learned some of the things that we last talked about, I've applied them a lot. And I thought a lot of the practitioners might appreciate learning a little bit more about a thyroid physiology from a framework perspective, thyroid physiology from a lab perspective, but you said something in the last call that I think was a really is a very valuable piece of information. We talked about a lab being an appropriate value and an appropriate scenario for the person versus an inappropriate value and an inappropriate scenario for the person. So basically, what you're saying is there's labs and then there's symptoms, and you have to marry these things up when you're working with people. So I also wanted to get into symptoms of dysfunctional thyroid physiology as experienced by the patient that may help practitioners get a greater understanding of how to assess that person and what maybe to do.
Hmm. Sure. You got it.
So that's a lot of stuff. In that, where do you want to start? Thyroid physiology from a symptom perspective, physiology from a conceptual framework, or do you want to dive into the lab stuff first? I'm going to leave that to you.
Well, I think we probably should start with the basics, right? Like to make sure that everybody's on the same page
Mhm.
because coming at this from a different level of uh, knowledge, different level of ignorance, a different level of bias, right? So
Mhm.
generally, when we think of hypothyroidism from a medical perspective, we don't typically provide um, the diagnosis of hypothyroidism until somebody has a TSH above the lab reference range. And depending on the lab, that could be like 4.5 is the upper limit. Some people say in some labs, I've seen it up to 6.0, but generally it's around 4.5 is the upper limit. So TSH would have to be above the upper limit, free T4 below the lower limit, and then somebody would typically get a diagnosis of hypothyroidism. Right now, a person could still experience hypothyroid signs and symptoms, even though they have a functioning thyroid gland that's producing enough T4. Um, but yet, so even though TSH and free T4 are in the normal range, they could still have signs and symptoms of hypothyroidism. And why would that happen? And that's typically because the thyroid gland makes primarily T4, which is essentially the pre-hormone or least less active form of the hormone. And then that hormone moves into the tissues, gets converted to the active form T3. That T3 hangs out inside the cell for a period of time and then goes back out into the bloodstream and becomes the circulating of level of T3, which then goes in and out of the cells until it's metabolized by the body. So you could have a functioning thyroid gland making enough T4, but because of some type of cell stress response, inflammatory response, um, the cells, specific tissues are not converting T4 to T3 at a high rate, and that is resulting in less T3 inside the cell, and that's resulting in hypothyroid signs and symptoms. And we call that cellular or tissue hypothyroidism. And that can occur in, you can have one tissue that's operating fine because it regulates thyroid hormone a bit differently versus another tissue. So each tissue has the ability to self-regulate its own metabolism, has the ability to self-regulate the amount of T3 inside it, and that becomes important. So people get frustrated about thyroid physiology because they say, my medical doctor is not paying attention, they're not doing the right tests. The reality is the medical community is monitoring two tests typically only because their goal or their guidelines or their job is to determine when you're supposed to give T4 based medication. Is somebody bad enough that they need T4 based medication? And the guidelines state that even if somebody's above the lab reference range of 4.5, there's disagreement as to when we should actually be giving T4 medication. Should we wait till somebody's above 6? Should we wait till somebody's above 10 before we actually provide T4 medication? Um, but the reason docs traditionally in the medical community, the only reason they look at those two numbers is because their job is to provide T4 medication when the gland can no longer make enough. Problem is a lot of people experience signs and symptoms long before then. And we talked about that in the past, I'm sure, about, hey, if there's an inflammatory mechanism going on, it's impacting the bowel is going to decrease T4 to T3 conversion. That's going to result in hypothyroid signs and symptoms within the bowel, maybe some constipation and inflammation. You could have problems uh, with biliary function because of decreased conversion of T4 to T3. You could have problems with the liver because of decreased T4 to T3 conversion. You can have problems with the kidneys because of T4 to T3 conversion. You could have glucose resistance because of T4 to T3 conversion is downregulated. But the medical community, even if you had enough, your TSH isn't lab high, the medical community may still say, even though you got those signs and symptoms, they look like hypothyroid symptoms. Our guidelines say not to provide too much thyroid hormone too early, because when we do that, it can create problems. You can shut down the gland's production completely, and it can result in sometimes worsening of symptoms
Mm.
because too much T4 can result in a decreased conversion. So that's glandular. Then there's this tissue component.
I want to
You
ask
know,
something before we jump into that, if you don't
sure.
mind. I want to
Yeah.
clarify two things. The first thing you said is you can have tissue specific hypothyroidism. Now, when you
Right.
see tissue, are you referring to an organ specific scenario, or are you referring to one of the four major tissues like collagen specific hypothyroidism or like more
Yeah,
organs?
I
Yes.
would say more organ specific. Yeah.
Okay. I think that's such a powerful thing because people don't think about that. They think it's likely an all or nothing, it's a switch. But there can be scenarios where, let's say, someone has inflammation in the liver, they have some kind of cirrhosis going on. You could have a situational state when there's an inflammatory response in a specific organ, but the rest of the body is actually maintaining thyroid homeostasis relatively normally. Is that a fair statement?
Yeah. Yeah. Absolutely. I mean,
Hmm.
especially
It
when it
makes it a
comes
little more
to
complicated, but it's good to know.
right, because and it's really important because the liver is highly dependent on how much T3 is in the bloodstream for function and physiology. Okay.
Mm.
So there's a lot of discussion, and you'll read papers, things, the literature's all over the place, but the general consensus used to be that most of the T3 in the body was made by the liver. The liver converted most of the T4 to T3. And then everybody assumed that the T3 probably had the liver had plenty of T3 because it was making it all.
Mhm.
A, the liver probably only makes about 5 to 10 micrograms per day. So maybe third of the T3 that's made in any given day is made by the liver. Maybe a sixth, maybe a third. And then two, that T3 that's made at the liver doesn't stay there very long. It's maybe in the liver for half an hour. And so it's generated by primarily D1 at the liver, deiodinase 1. That any deiodinase 1, it's thought that any of the T3 that's generated by deiodinase 1 only hangs out in the cell for about 30 minutes. The T3 that's generated from T4 by deiodinase 2 hangs out in the cell close to 8 hours. That's impactful. And it'll be kind of the rest of the conversation, because if I can keep the T3 in the cell for 8 hours, I don't need as much T3 in the circulation to potentially have a powerful effect. Versus if I'm putting people on T3 medication that's only going to hang out in the cell for 30 minutes, I may need a lot of T3 to
And
try
I'm
and
gonna
have.
down-regulate that conversion by having a surplus of external T4 coming in.
Yeah, but yeah, if you're taking T3 or T4 too much, can both down regulate the deiodinases. Yeah. So yeah, it's a big story. So if we jump back, so that's glandular hypothyroidism and tissue hypothyroidism. Allopathic medicine says we only really need to give T4 because that's the primary hormone, and the peripheral tissues are going to convert T4 to T3. They just make the assumption it's going to happen. But in functional medicine, we see people coming in who have chronic hypothyroid signs and symptoms with still a normal TSH or a TSH within the lab range. But we also look at the T3 and free T3 levels and reverse T3 levels, so we can see that, yes, the person has decreased conversion of T4 to T3, and that's probably resulting in hypothyroid signs and symptoms. And I think the biggest challenge from a functional medicine standpoint is that instead of saying, okay, why is this happening? We oftentimes jump to, well, then if they're not converting T4 to T3 at a high rate, we're assuming that that's broken physiology and saying we need to give T3 too. We need to give T4, we need to give T3. If they don't convert well, then we need to even give more T3 because the physiology is broken. And you and I have talked about this a lot. It's usually not broken physiology, but adaptive physiology. And yes, adding T3 to these people can give them a honeymoon period where they feel good, but there's consequences to pay. One is if there's still this inflammatory cell stress mechanism going on, you're going to provide T3, which could potentially increase oxidative stress. It could definitely initially probably make somebody feel better. But then we talked about you get more suppression of the thyroid gland, you get more potential activation of the sympathetic nervous system, which ramps up fight or flight and inflammatory mechanisms. And the body starts maybe increasing the deactivation of T3 because of that whole inflammatory cascade. So what worked initially doesn't work as well. So now I need more. And then it's because I take more, now I got to deactivate more of that. And so now I need more again. And it starts this vicious cycle of never finding the right amount. It's like a drug addict chasing the high again, right? The first high
Yeah.
was always the best and they can never get it again. And this leads to a massive over medication from the integrative community, where they're like, okay, we'll do add T3. Oh, now we need T4. Now we got to add more T3. Now we're going to do T3 only. Now we're going to do high dose T4, high dose T3, and the whole thing becomes just,
Cluster mess.
um, yeah, a mess. It looks like a Jackson Pollock painting, right?
There you
Like we just throw shit at the canvas and hopefully it works.
But some
So
people call that abstract, Eric, some do.
yeah, right. And
A
some people
and
call what we're doing in functional medicine,
abstract,
functional
yeah,
medicine, and I don't
yeah.
necessarily agree that that's the case.
Well, and I'm just gonna try to summarize that because I think all of our brains are a little abstract after how many connection points are there. So basically, you said there's two main types of hypothyroidism: tissue
Mhm.
specific, glandular specific. And I would imagine it's probably fair to assume, not always the case, but potentially likely, if you have tissue specific hypothyroidism that manifests as a systemic problem, it will probably lead to systemic glandular hypothyroidism if left unchecked or mistreated. So there's got to be a connection point there.
Yeah. So if you have glandular hypothyroidism, you're going to have tissue hypothyroidism, right? Because
Yeah.
there's not enough thyroid hormone in the system.
Mhm.
If you have tissue hypothyroidism, you may at the moment not have a glandular hypothyroid state, but the same inflammatory mechanism
Mhm.
that triggered the cell stress response and the decreased tissue conversion of T4,
Mhm.
T3, those same inflammatory signals, what we call DAMPs and PAMPs that are in circulation, activate thyroiditis, they activate the immune system. So in time, yeah, you're going to
Will become.
eventually wind up having thyroiditis
And I think that's so
and glandular
impactful
hypothyroidism.
for clinicians to hear because although it gives you more to think about and more to have to know and understand, it reinforces the chicken or egg scenario where it's like the body doesn't make a mistake in terms of how it conducts itself. It's trying to compensate and figure out the best way of operating to keep you alive while the machinery may not be working optimally. And this is why it can be confusing. And I like that you mentioned you can have people who have horrible labs, but they feel okay, and you can have people who feel terrible but have normal labs. And I think in medicine, we default to the piece of paper a little bit too much, and we maybe eschew them of more so symptom analysis or gathering of presentations of symptoms. What would an example of either or in a person potentially? I know there's a wide range of effects. What are things that people should look for in both tissue and glandular hypothyroidism?
So, from a symptom standpoint, I mean, the symptoms could be really dependent on, which tissues are affected. Definitely, we see problems in the bowel. You're going to see problems potentially with constipation. I see also some people, even though constipation is kind of the thing that's often talked about, I also see those people have loose stools as well, maybe irritable bowel syndrome.
Mhm.
You need thyroid hormone to support GI motility and GI function, but you also need thyroid hormone to support bile function and biliary function. You need it for liver function. So to actually generate and create bile, you need thyroid hormone. To If you don't have appropriate bile production and bile physiology, then you're likely going to have dysbiosis, so gas, bloating, pressure. You need thyroid hormone to support stomach acid production. So, hey, could this be a person who has hypochlorhydria? So any it's terrible to say, but any GI symptoms could be the result of reduced T4 to T3 conversion or some tissue hypothyroidism, and which tissue it impacts. Could it be just biliary function? Could it be stomach production? Could it be motility? Um, could be any one of those, right? So we have to look at all those things. The quick thing to keep in mind is even though we go, okay, person has symptoms of hypothyroidism affecting, they have low stomach acid, they have gallbladder issues, they have um, reduced motility, they got irritable bowel syndrome, they have dysbiosis, they have a thyroid problem. Look at a thyroid panel, they have low T3, give them T3. No, what we have to do is then say what's causing that reduced conversion of T4,
Mhm.
T4 to T3, not just give it. If we look at somebody's um, periphery, they may have a lot of uh, puffiness or edema because they can't get um, fluids essentially out of the system as effectively. So there's like a mucopolysaccharide that's underneath, like it's in under the skin, and essentially it's like a sponge. And thyroid hormone T3 helps make the enzyme that kind of breaks that mucopolysaccharide down. So the sponge builds up, and then T3 helps kind of squeeze out the sponge to move the fluid into the lymph and into the tissue, so that way we can excrete it. But you also need T3 at the kidney to help with GFR, glomerular filtration rate. So as you have less T3 affecting the kidney, they're going to have not be able to pee that stuff out. So we get fluid retention. So you get fluid accumulation in the soft tissue, and you get fluid retention at the tissues. And if you got more fluid and you got more volume, then could that increase things like high blood pressure? Sure, right? So it can have multiple effects. You can have impacts on the cardiovascular system. Some people get, we talk about heart palpitations is like one of the most common things people get. That could be from too much or too little thyroid hormone. Um, Brain-based issues can be associated with hypothyroidism for sure. Tiredness, fatigue. We can get challenges. We typically think about eye issues. We talk about more hyperthyroid symptoms with eye issues, like with the eyes popping and bulging. But keep in mind that the eyes are like the extension of the nervous system, and that T3 is helping drive the mitochondria to make energy, and you're not making sufficient cellular energy, your nervous system is not going to function well.
Mhm.
So the another big thing that we can see is glucose regulation, and you need T3 to help for the pancreas to work appropriately, especially when it comes to insulin production. So we can have problems that result in glucose regulation issues due to glucose resistance because of D3, T3 in the peripheral tissues, liver, and muscle tissue. And we can see glucose resistance issues because the pancreas is affected and glucose is elevated, but insulin is low.
Mhm.
The other thing we might see is we may see challenges with cholesterol physiology. So we'll see elevations of cholesterol because if I have reduced T3 in tissues and then I have a reduced ability to convert glucose to ATP or cell energy, that essentially the glucose coming out of the Krebs cycle is going to be converted into cholesterol. So it can be utilized as a make into hormones, cell membranes, or excreted. But to get cholesterol into, say, the adrenal gland, I need HDL to dock to the adrenal tissue, and that docking mechanism requires T3. So without T3, I may have reduced, may have elevated cholesterol, and I may have um, lower adrenal hormones. If I have low T3 in the bloodstream to support the liver, then the liver may not be able to, the LDL receptor, the LDL cholesterol may not be able to dock to its receptor to get the cholesterol out of the bloodstream into the liver to clear it through bile and get rid of it. So we can see cholesterol build up uh, in in the bloodstream. So multiple tissues. Skin can be compromised, hair can be compromised. So it's so vast of what type of symptoms there could be. I think that's one of the reasons it often gets written off when there isn't an elevated TSH and low free T4 is because people say, well, those could be symptoms of anything. Well, of course they could, because they're not necessarily symptoms of a thyroid problem. They're indications of altered physiology for which reduced conversion of T4 to T3 is just one of the mechanisms.
Yeah, it's systemic metabolic dysfunction, which collects different scenarios as part and parcel of the issue.
Mhm.
I remember in school we were taught that if someone's hair doesn't grow or if they have like dull skin, that could be a sign. If they have poor cognitive discernment or the inability to have higher frontal lobe activation, something as strange as even if the outer part of your eyebrow hair starts to thin out, it's typically a sign of this is more glandular thyroid dysfunction. But the one that I think is so impactful is the inability to make body heat. We have these things
Mhm.
in our mitochondria called uncoupling proteins, and they take the electrons that flow down the gradient and they just let them fall through a membrane to generate infrared energy, which is heat. And if you don't have enough active thyroid hormone to dock to specific cells and generate this effect, then that's why someone's got cold hands and feet all the time. They have vasoconstriction. A lack of thyroid hormone is a precursor to, I think, an overall assessment of how much energy someone's body potentially has at any given time, which is why I think as a clinician, If you default to just the paper, you've missed potentially 80% of the clues because if there's a metabolic problem, there's usually an inflammatory problem.
Yeah.
There's likely a thyroid problem, there's a nutritional deficiency problem, there's a digestive. There is nothing that's separate in the body, but there are major nodes of the network that are important to know to figure out how to reverse engineer the problem and figure out why it might be. Not necessarily how to resolve it immediately, but it tells the story. And I'm glad that you went into all those symptoms because I hope people were taking notes because it was just about everything that could go wrong with someone.
Yeah, and the challenge is that when we think about that uncoupling protein piece, right, and we talk about the dissipation of energy as heat, can that have effect on temperature? Sure. Then we've got other mechanisms with adrenal receptors and adrenergic receptors, and but the issue becomes this is a real challenge because if you eliminate those uncoupling proteins, um, because of the cell stress, inflammation, downregulation of the uncoupling proteins. This makes sense for why people become glucose resistant, right? So when we're at high tilt, high energy, like we have healthy cell physiology, we can any excess food calories that don't need to be converted into cell energy can be dissipated as heat, right?
Mm,
So we could put a lot of energy through the mitochondria become less. It sounds weird, right? But I know you'll understand this part. The mitochondria becomes less efficient at generating energy because it's dissipating excess as heat. But as we become more hypothyroid, the mitochondria actually becomes more efficient in taking that food energy and driving it into cell energy. It just does less of it.
mhm.
Right? So,
It's an adaptive response to deal with the stress of energy supply.
right. Exactly, right?
Mhm,
So if I have that stress response, I also have reduced oxygen, right? I have reduced oxygen coming into the tissue. I can't run this uh, atomic generator at full tilt, right? Without this added oxygen. And so we have to, reduce some of that, some of that function as part of the adaptive response. It's also my argument for why we shouldn't be forcing too much thyroid hormone into a body that's not ready for it. Because if we add more thyroid hormone to a system, then we run the risk of increasing oxidative stress,
mhm,
pushing more mitochondrial density, pushing more complex one without the ability to regulate the rest of the complexes,
mhm.
especially complex two. And now we get lots of unhealthy mitochondria that are just generating massive amounts of oxidative stress. Is the short-term benefit worth it? I don't think so. So,
Not when you know that gaining excess weight is a protective mechanism at its core and not a problem. And this is the reality. On one end, you have weak mitochondria that will predispose you to adding body mass. On the other end, you'll be skinny, but you'll rust from the inside out.
mhm.
Versus two, because one is more long-term manageable, whereas the other one is the reason why people with high amounts of inflammation who don't have the ability to get fat typically drop dead of heart attacks before the age of 65. They don't have that protective mechanism from their own internal inflammatory response.
Yeah, I'm glad you brought that up because I bring this up quite a bit. Like, I think some of the people that develop Hashimoto's, this is going to sound weird, but the people that develop thyroiditis Hashimoto's um, are probably to some degree lucky. It just
Hmm.
sounds weird, right? Because if I have this inflammatory process going on, I do want my body to respond to some degree. The challenge becomes if you have it and you don't address the underlying mechanisms and just throw more hormone into the system, you're in trouble. But if you are aware that, okay, now not only do I not convert it well in the tissues, but now I'm getting damage to the gland, my body's really potentially trying to slow down metabolism. Um, then they are at a much lower risk of a number of things. And this goes back to the paper Kelly and I talk about is the 2019 paper on the incidence of uh, different types of cancer in people on thyroid medication. It's significantly different. There's a no, there are, they ran through this paper, my premise to Kelly was if thyroid hormone has the ability to bind to receptors, integrin receptors, and cause cell replication, um, or cause cells to replicate, that's just part of what thyroid hormone can do. If we put too much thyroid hormone into a system that didn't want it to begin with, do we increase the risk of cancer in people? And we both agreed that nobody would ever write a paper on that because it'd be like professional suicide.
Career suicide.
Yeah. So in 2019, somebody did a meta-analysis looking at all the different types of cancers and did people on thyroid medication 5, 10 years after being diagnosed with hypothyroidism and be put on medication have any greater risk of any cancers than anybody else. And it was a long list of cancers that were greater in people on thyroid medication. So what did that lead to? That then led to people saying, huh, maybe hypothyroidism is a protective response against this abnormal cell development. Now, unfortunately, we don't have great tests all the time that we can look at when somebody's got hypothyroidism and say, oh, could this person be developing abnormal cancerous cells? Um, Maybe they are. But if we don't, if we what gets measured gets managed. So if we don't have a way to truly, like with what is it, Scotty, with his
Yeah.
little thing that he
Little
ran over
beep,
the
yeah.
person, right? Yep. Since we don't have that level of specificity, um, and we don't typically think holistically like that. We just say the person's hypothyroid is just a gland thing, just put them on thyroid medication. But then you look at a paper like that and say, holy cow, we could be increasing the risk of cancer. We already know that almost everybody who goes on thyroid hormone replacement has increased bone loss across the board. So we're increasing cancer risk, we're increasing osteopenia and osteoporosis. Maybe we're not really doing the right thing
Mm-mm.
over globally. Somebody would be like, what? Oh, so what do you want me to do? Is suffer? Well, no, we don't want you to suffer. If you need some to function, we want you to take the least amount possible to maintain some level of function, but we shouldn't be trying to optimize blood levels to the level of a euthyroid healthy individual for whatever that means. What we should be doing is trying to just say, hey, we just need enough T4 in the system to run it. And then we need to help you figure out how to convert the T4 to T3 appropriately versus trying to manipulate the blood levels into somebody's predetermined optimal range.
That's absolutely brilliant and as a sentiment. And to comment on the former, I think there's got to be some connection between the loss of internally regulated rhythms, biorhythms, and various aspects of functionality as it connects to what you said that you read about, i.e., thyroid hormone causing disruption. Because if you dysregulate the internal processes and cycles of rhythms and regulations in the body, well, cell growth is a regulated cycle and rhythm, right?
Mhm.
There's something to that. I think you and I should definitely talk offline a little bit more about that because we'd be here for 3 hours if we really dug into it. And I want to respect everyone's lunch hour. So you basically beautifully encaptured the lab aspects, the symptom analysis aspects. People are so curious as to what to do. What is the right thing to do? And I know you're going to say, well, the right thing for who, under what circumstance? So, what I
Mhm.
want to provide today is not a lesson in crafting protocols, but a lesson in critical thinking to then allow you to come up with a multitude of different things that could intervene positively with a person, i.e., are there dietary strategies? What supplements do you look at, or how do you frame supplement choices based upon looking at a lab or doing a symptom analysis? Are there any lifestyle things that you have found to be incredibly successful for people? And what can you expect people to potentially experience as they get out of a hypothyroid state systematically? I know it's a lot of questions, but why don't we start at like what are the things that you immediately think about? Someone comes in, symptoms are presented, labs don't look very good. Where are you starting?
So are we talking about the person who's already on thyroid medication? Or are we talking somebody who's not on medication and they've been told, hey, you don't have a thyroid condition?
Let's talk about the thyroid medication because I'm assuming a lot of people will see this because it's unfortunately commonplace if the first step is go
Mhm.
to the doctor, get thyroid medication. Let's go there.
So one of the first things I will take a look at when I look at somebody's health history, health timeline, do they have signs and symptoms that indicate that despite maybe taking what somebody deems an appropriate dose of thyroid medication, do they still have hypothyroid signs and symptoms? And do they have hyperthyroid signs and symptoms at the same time as a result of the medication? So that's one of the first things I want to look at. Like, where do their symptoms look like, and do I have? Do I have just more hypothyroid signs and symptoms? Do I have hyperthyroid signs and symptoms, or do I have a mix? You can pretty much guarantee that if somebody's got an inflammatory cell stress response and they're on thyroid medication, they're going to have mixed hypo and hyperthyroid symptoms. Brain hyperthyroid, anxiousness, anxiety, depression, disrupted sleep patterns, brain fog, uh, all classic symptoms. I have one client who I spoke with yesterday, night tremors, nightmares from being massively over medicated. Um, but they still might have hypothyroid symptoms peripherally. Like, I got constipation, I got GI issues, I got reflux, I've got dry skin, my hair's thinning, eyebrows going away, low libido, hormones dysregulated, like multiple indications that there's downregulation in the periphery. So that if I once I kind of get a gist of that, then I want to look at their thyroid medication and say, okay, what is this person taking? What were they taking at the time of the test, and what was the timing of the labs in relation to their medication? For me, when I'm looking at a new client and their blood work, I do not want them to take their thyroid medication the morning of the blood draw, whether they're taking T4, Armor, T3. I don't want to see it. I want to see who they are without the thyroid medication. And because I'm not a doctor who prescribes medication, what I'd really like to do is see them with maybe a week or so off medication, but I can't do that because that's outside the scope. But I just tell them, just don't take your medication the morning before the blood draw. Why? The T4 has a half life of 7 days, so the T4 really wouldn't affect the values too much. I just want consistency. T3 will dramatically affect the lab values, and not just the thyroid panel, but other lab values as well. So I don't want them taking any T3. I want to see what what their thyroid gland is making of T4 between their what they're taking and what their thyroid gland's making of T4, and then what their thyroid gland might be making of T3 and what their peripheral tissues are converting. So I want to look at that way. If they have that reduced conversion of T4 to T3, and I look at the free T3 to free T4 ratio, I'll look at T3, total T3, free T3, reverse T3, total T4, free T4, T3 uptake. I look at all those, and we don't have enough time to get into all of that stuff, but the free T3 to free T4 ratio is very important to me, um, because I want to know how well are they converting T4 to T3 by just looking at those values. Now, if they're taking T3 medication, it's going to skew those values because you're measuring some of what they're taking. But if you can get them 24 hours, no T3 based medication, the half life of T3 is arguably someplace between 12 and 24 hours. You're really not seeing much of the medication in that.
Mhm.
Okay. And so then the next thing I'll want to do is say, yeah, yes, it looks like they have an underconversion. They're cell stress. Let's see if there's inflammatory mechanisms going on in the labs. I look at uric acid levels. I look at bilirubin levels. I look at fibrinogen levels. We look at homocysteine. We look at high sensitivity CRP, alkaline phosphatase. There's a number of things we can look at. And those inflammatory markers give us a general idea of inflammation, but they also give us an idea of what cells or tissues may be struggling, right? And where some of the challenge may be coming from, and potentially how to address those things. And then the next thing I'll do is look at the rest of the uh, blood panel that I typically run to see what tissues or systems are being impacted by the tissue hypothyroidism. Do I have a glucose resistance issue going on? Does it seem like it's impacting muscle? Is it impacting liver? Do I have elevated lipids? And do I have elevated cholesterol, LDL, maybe high or low HDL? Or do I have elevated triglycerides and VLDL? Or do I have a combination of both of those? Where's the GFR? What are some of the GI-based markers looking like? Do I have indications that I have gallbladder issues? So I'll look at all those things so that I know what systems are impacted by it. And then the next thing I want to do is make a decision as to what do I need to do with their current medication to make it more appropriate for the individual sitting in front of me. So I'm not trying to optimize to them as if they're in homeostasis. I know they're not. This is why they're not managing well and the doctors can't figure out the dose. So I don't want to do that. I just want to make sure that they have enough T4 in the bloodstream, total T4 in the bloodstream. People would say, well, you should look at free T4 because that's what gets into the cell. But the level of free T4 is going to be influenced by how much T4 medication or T3 medication we're giving, plus the amount of estrogen. So there's a number of factors that can affect how much gets free. I just want to know, do they have enough total in the system? If they've got enough total in the system, then it's my job to help them get that free by changing things like temperature, pH, inflammation, hormone regulation. So it just need enough total in there. And then my job is to help them with figure out how to get it to convert. And so then once we make that decision that what needs to change, maybe we need to reduce the T4, maybe we need T3 to be reduced or eliminated. Maybe we need to have maybe we need more in there. Depending on how much excess medication they're on, that may be a step down process over months to step them down on this dose because too much thyroid medication will create problems and it'll make it very difficult to actually get tissues to heal, especially something like the gut. Can't tell you how many people chronic gut issues and they've done so many gut protocols, they can't figure out how to get it better. Well, they're overloaded. Their TSH, somebody wants their TSH like under 1 or in the 1 to 2 range inappropriately. And to get it there with the state they're in, the dose that they need is creating saturation in the hypothalamus and other tissues, well, really up regulating that sympathetic nervous system, down regulating the parasympathetics. There's no way their gut is going to heal with over medication. So that becomes a critical piece. And I urge all the clinicians that are listening to this, whether you agree with me or not, if patients aren't converting T4 to T3 appropriately, you should not be forcing more thyroid hormone into the system than is absolutely necessary. And you should not, in my opinion, if you're a functional practitioner actually trying to address the issue, they should not need more than 5 to maybe 10 micrograms of T3 because that 5 to 10 micrograms is essentially what a healthy functional thyroid gland would have made. Everything else is peripheral conversion. Now, some people say, what about the people who have deiodinase 2 conversion issues? They might, but they've had that their whole life probably. So we're less worried about that. But if they need more than 5 to 10 micrograms of T3, then they've got a gut issue, they've got an inflammatory issue, and you saturating them with more T3, 20, 25, 30, 35 micrograms or more of T3, it's just creating more dysfunction. And so as we're working on that, then the next big thing that we really want to focus on is what can we start to do to manage, not eliminate the inflammation, but manage the inflammatory process? Because we don't want to eliminate, because obviously something's triggering it. We don't know if the thing is still there or the immune system's in a dysregulated state because they've been this way for so long. But what can we do to manage the inflammatory process? And that's where the lifestyle pieces are important, but this is where we can really use some of our supplementation strategies, like especially from what US Enzyme has. We've got sulfurizyme, which upregulates NRF2 and downregulates NF kappa B, the big inflammatory driver. And then we have a bunch of our systemic enzymes, nattokinase, and some of these other things that are triggered by the inflammatory process. So if we can calm those things down, not eliminate them, but calm them down, we can try and get, while we're trying to figure out what's driving the process and driving the inflammation, we can get these situations under control much faster.
It leads me to a question I'm actually curious about. Do you find that there are any supplements or products that seem to synergize with a reduction of someone's thyroid hormone well? Are there things that really seem to, like systemic enzymes, under scenarios where someone needs to use antibiotics, for example, they actually might create a synergistic effect? Or when you on an antibiotic and you use a probiotic concurrently at a different time, it minimizes the collateral damage. Are there any scenarios to where you use something regularly that works well with a person as you're reducing thyroid medication levels?
I, not to be biased necessarily, but I do utilize a lot of the sulfurizyme because of its impact on NRF2 and systemic inflammation and oxidative stress. So if we can manage that, um, and I know there's some concern that, oh, it's from broccoli and broccoli is potentially goitrogenic. That has not been proven to be true at this
What's
point.
the
So
least of
people,
their problems if they have a
right, right.
massive dose of thyroid hormone?
So we don't have to worry about that. That's been proven. But um, if and there is literature kind of showing that it can reduce some of the inflammation associated with thyroiditis and calm the immune system down. We do know sulforaphane can get to the brain. I think it's within 15 minutes of taking it, so it can calm down the brain-based inflammation. So I think that can be effective. Um, and so if we reduce the inflammation, yes, we can see synergistic effect with thyroid hormone because now we're increasing the conversion of T4 to T3, and now our need for thyroid hormone actually goes down. And we can start to see the thyroid gland potentially start to recover physiology. Now, it's thought that maybe 70% of those on thyroid medication are on it inappropriately, which is a huge number.
A big number.
Um, yeah. Um, so is it realistic that a thyroid gland can recover? I say yes. I I see it happen all the time, but I don't think thyroid glands are as damaged and diseased as we think they are versus they're been inhibited because of the massive quantities of thyroid hormone we're putting into the system and suppressing TSH. So essentially what you're doing is turning off the gland's ability to work when you're saturating so much thyroid hormone into the system. Um, but the other products that could be really beneficial are really dependent on, like, what do we see? I mean, if we saw, you'll see this a lot of patients, especially women, they'll have higher levels of fibrinogen when they have some inflammatory mechanisms going on. So the inflammation's triggering more fibrinogen. And why is that a problem? Because you get increased viscosity, you get increased clotting effects. But I mean, US Enzymes got a number of products, especially their nattokinase, which is, that's one of its claim to fames, is that it can reduce the fibrinogen and therefore reduce clotting, reduce platelet aggregation. So yeah, there are a number of products that we can use to, again, kind of reduce the inflammatory response without turning it off massively, like a drug-based approach. So we can still calm it, and by calming that inflammatory response, we can get a natural improvement of the conversion of T4 to T3, and we can get natural improvement of thyroid production, um, helping us need less thyroid hormone over time.
That's awesome. Thank you for adding that because I know a lot of people are curious. We know sulfurizyme is your baby, and it's been something that we've had wonderful feedback from a multitude of practitioners and how effective it is. But it's how you framed it there was that synergistic effect, I think, is really important to understand. If someone's developed a thyroid issue and they've been on thyroid medication for a few years, they've likely had a metabolic issue for much longer than they've been on thyroid medication. That's just when it was too much for them to just take anymore. So they finally went to get an intervention. I think it's important to understand that these processes, generally speaking, you have to get the variables right in the right order, and they do take some time to resolve. But when you get it right, the body is an amazing thing. And I like that you mentioned the concept of the thyroid gland not being diseased. I don't think there's anything to say that a tissue that's been damaged, once that damage has been restored, can't find itself back to a vibrant state of health and optimal function. I think we need to understand that it is a process and it is not just simply a thyroid medication reduction. It is not simply the addition of supplements, although both things are very impactful, both acutely and in the long term, but it's the synergy of all the other things, the diet, the lifestyle, the circadian, the sleep, things of that nature that really move the needle for people. Do you find that there's a period of time on average, every case is different, I understand, but on average to where your patients really start to see and feel changes once they've been under your care?
Yeah, I had to do kind of a summary for a third party recently. So I went back over the last 3 years and looked at um, change. And so usually, if I'm working with somebody, I typically will say, "Hey, we should expect some change within 6 months of working together." Okay. And I went back and I've been saying that my patients usually somewhere between a 70 and 80% improvement of signs and symptoms in labs in that 6 month period of time. Um, Obviously, some people are all better, and some people are still we've still got a lot of work to do. But I was saying that, but then when I went back over the last 3 years and looked at everybody that I've been working with and where they were after the first 6 months, and it was 73% improvement of signs and symptoms in a 6 month period of time. Um, Now, are there ones that are far less than that? Sure. But I think the people who are following the what I propose, they're coachable. They're doing what we talk about in the book, the fitness factors, and working on their diet and their lifestyle and their mindset, their sleep and their respiration. Um, they get better faster versus the people who aren't doing those things and hoping that the supplementation is going to fix it. There aren't enough supplements, and I know this is master supplements, and they may get upset if I say it, but there aren't enough supplements to fix bad habits and bad behavior. There just isn't. They can manage signs and symptoms. Drugs can manage signs and symptoms, but you can't. There isn't a supplement that I know of yet. There isn't a drug that I know of yet that fixes bad habits and bad behaviors that are done consistently. It doesn't work. Um, so yeah, you people should be making changes, and sometimes the changes that people want, especially no offense to the women, but usually the women, the number one thing they want in this category of people is they want to lose. They say they want to lose weight. What they really want to do is lose body fat. Um, and they often will lose 5 to 10 pounds, maybe right at the start with changing their diet and doing a couple things. They'll lose 5 to 10 pounds, but that's usually not body fat. That's usually okay. We're regulating thyroid physiology. We're reducing the inflammation. They've lost water volume. Um, and then they plateau and they want to know, when am I going to lose fat? When am I going to lose fat? And this is so important for us as clinicians to keep in mind because we want to help them. They are not going to start burning body fat until the danger physiology is over.
Thank
And
you for
so,
saying this. The
so we
body
want,
moves only as fast as it wants to move.
right. You said at the start, the storage of excess food energy as adipose tissue is an adaptive response to danger, right? I need quick energy, fast energy. Anything I can't use right away is going into storage. And I'm not pulling that stuff out of the storage. That's like my prepper storage stuff, right? In case the end of the world
That's your
comes,
doomsday
right?
bunker right
Right.
there. That's your doomsday bunker.
So people want that to go first. And I'm like, you're not losing body fat. I know that's what you want to do, but what about Ozempic and what about this? They'll help. They're not fixing issues. They are not fixing problems. They're
They're going to
managing
create other problems down the
yeah,
line.
they're managing a gut situation. You're losing primarily muscle mass unless you're really doing high protein along with it. Um, but ultimately, the sign that you're not losing the body fat yet means that we still have got this inflammatory cell stress response kicking in. And that's where we have to start to ask the bigger questions like, okay, I'm eating a healthier whole food diet. I've done some gut-based protocol support. I've done some liver detoxification support. I'm doing some working on my respiratory stuff. I'm working on trying to get better sleep. I don't know what else is wrong, right? I don't know what else it is. And this is, we talked about this the other day, and you asked this as when you gave me the long list of things you wanted to cover, right? I don't remember all the things you wanted to cover, and I'm sure we're not going to get to them all, but what thing tends to have the biggest impact on people's overall physiology, on their improvement of inflammation, on their ability to lose excess body fat? It's what goes on between the 6 inches of their ears on a daily basis. Okay. And it's sometimes it's conscious, sometimes it's unconscious, but what goes on in between the 6 inches of their ears makes a decision, makes the determination. And we talk about stress creates health problems. Stress creates stronger muscles. Stress creates resiliency. Stress creates a lot of good things. It's chronic, excessive, perceived stress that creates a problem. And what I mean by that is two of us could experience something and one of us perceives it as danger and fear, and the other one says, not a big deal. It's the same stressor. But because I perceive it as danger, as I perceive it as fear, and I continue for an extended period of time perceiving it as danger, threat, or fear, my physiology is going to shift from homeostatic regulation to allostatic regulation, and I'm going to upregulate the immune inflammatory process and downregulate metabolism. At the end of the day, that has the most impactful challenge, because people say, well, you're telling me I'm not going to have stress in my life. No, you are, and you need it. I stress my muscles every day, right? So that I can have bigger, stronger muscles tomorrow. So is that damaging or bad? Well, if I did excessive physical exercise and stress without recovery, yeah, it would be bad. But if I do it, small dose, tolerable, let rest and recovery, and I'm good. If it's emotional stress and I perceive it as threat or danger, but then I move on past it, right? Then it's not as big of an issue. But if I perseverate on it and I keep thinking about it and focusing on it and worrying about it and allowing it to change my physiology and wind up my limbic system, I'm screwed. There's no way I'm going to get healthy. No aspect is going to get healthy for an extended period of time. And I think that's what people don't want to work on or don't want to be willing to work on, at least in the beginning. It usually is not the first thing people want to talk about. They go, I'm doing a therapist, I'm doing that. Well, you don't want to say, listen, the therapist is not working because we're talking, right? But because we're talking today. If the therapist was working, we wouldn't be talking, you wouldn't be having these problems. But in time, it's a huge aha moment for people when they realize not that it's them, right? Like they're like thinking, oh, you're telling me it's my fault, but it is the constant upregulation of your limbic system by your perception of your environment that's going to trigger issues. If you had trauma, talking to a patient the other day, narcissistic parents, and she spent her whole life stressing over them, and we had a conversation. I'm like, you got to let it go. You're dragging your parents' problems through life with you like a big overweighted backpack. There's no way you're going to be healthy. You got to let that stuff go. You're saying I need to this break off communication with my family. Yeah, maybe you do. It's not your problem. You tried to fix it. If it's their problem, let them have their problem. You'll love them more if you break off the communication than if you constantly are fighting them and thinking it's your fault. Stop feeling guilty. If they have issues, let it be their issues. Empty your backpack out, and it's amazing how much people feel and function better, and chronic conditions all of a sudden start to feel and function better, and people start losing the excess body storage because of the mindset shift that changes their physiology.
See, this is why I said maybe you are the master classes, because that was like some sage wisdom that you dropped at the very end of this talk that I think is so impactful for people to hear. But there's a perspective shift that I just want to utter before we wrap this up, that when someone says to an individual, maybe something in your life is driving this, and if they take it as you're accusing me or triggering me, say everything that you've created in your life, directly and indirectly, is your fault if it's happened to you or your body. Now, it doesn't mean that you're in the wrong. It doesn't mean that you're intending on doing said things to yourself, but one has to understand challenges that you create for yourself are also opportunities to grow. Some of the best healthcare practitioners have become so from the depths of their own suffering because it's what they needed to understand the process for them to be able to teach it to other people by going through it for themselves. So, anyone as a practitioner who is listening to this will listen to this as a patient. Accepting responsibility of all that happens in your life and all that has happened, it's just part of your story. And the things that you use strategically, supplementation, medication, diet, lifestyle, we're just a supplement company. We spent an entire year covering the fitness factors. So Jeff and Jeff are entirely under the impression that there's so much more out there than simply a supplement. Thankfully, our well as synergists in this healing process. But I want to thank you for saying that at the end because it is the wise words of wisdom that women, but even more importantly, men need to understand if they want to take care of themselves. And just to end on your end, end on something that may be valuable. I've never met someone with a thyroid problem who can effortlessly articulate their own problems. So, if we go back to Eastern medicine and the throat chakra and the expression center, they're physical, mental, psychological, emotional, spiritual, it's all part of us as an individual. So, I'm really glad it went there. I didn't expect it to, but I'm glad that we got to end on that note. So, we've gone a little long. I thank everyone for their tolerance and their patience, but I'm sure they could have listened a while longer. I know I could have. Eric, anything that you want to end off with, anything that you're working on that you want to let us know about, or just a message that you want to send to the people who are going to listen to this either now or after the fact?
I appreciate the opportunity. I know there's been some questions regarding like dosages and how much somebody from the sulfurizyme perspective, how much does somebody need? Uh, Roland and I are probably on the same page. We have no idea, right? You have to challenge people with things, tinker with the dose. The dose for one people may be different for somebody else. I know somebody asked me the other day, like how much sulforaphane for somebody who has this condition? How much for this person who has this condition? Our job is not to prescribe supplementation based on conditions. It's based on the individual that's sitting in front of us. So don't think of what's the protocol for a condition. Think of let me let me see what's tolerable and manageable for my patient and if it's appropriate.
Mhm.
The other thing is, if you want more information regarding what some of my thinking, the book that Dr. Kelly Halderman and I wrote called "The Thyroid Debacle" is out there. Go purchase that. We also have a course that's available that kind of walks through the book and how I look at blood work and make interpretations on things. And of course, we spend a bit talking about the fitness factors and what you can do for your patients and what their patients can do for themselves to improve their habits and behaviors and their well-being without supplementation. It's really meant to be help for the patient, but even any clinician could use that part 3 of that book and just pull that stuff out and say, okay, these are the things I'm going to work on each time I meet with my client. I'm going to work on their fitness. I'm going to work on their sleep, their respiration, their mindset, their habits, so they can just work through those pieces. Those are the pieces we all need to work with on our patients if we're really going to truly help them restore their health.
Awesome, dude. And I will say there's an incredible lecture on our YouTube channel that you gave on the cell danger response. So I think everyone would benefit from brushing up on their knowledge of that because it can be applied to more than just the thyroid. It happened to fit the narrative for what we wanted to speak about today. So on that note, Dr. Eric, thank you for coming. I think you've done enough to come back for a third time in the future. We'll see what the crystal ball tells us.
All right, my man. Thank you. Take care, everybody.
All right, have a good day, everyone. Thank you. Take care.